This discussion is going to center around the biomechanics concepts of the shoulder complex. So what we're going to do is look at the entire anatomy, some basic anatomical considerations of the shoulder complex, and then get into some of the arthrokinematics associated with all the joints of the shoulder complex. So here we have an illustration showing the basic bony anatomy of the shoulder girdle. And when we're referring to the shoulder girdle, we're looking at all of the different joints and articulations that are involved. So obviously the primary joint, the glenohumeral joint, or the actual shoulder joint, and then you also have the other parts of the shoulder girdle, which is comprised of the scapula, clavicle, and the manubrium, and the joints associated with that, the sternoclavicular joint and the acromioclavicular joint. So in looking here, you also have the scapulothoracic articulation, and we'll talk about the significance as to how that's oriented. If you look at the scapula, so the scapula kind of being the base of support for the humerus, the plane of the scapula is rotated on a vertical axis about 35 to 45 degrees. This kind of places the glenoid facing slightly anteriorly on the body. So again, so the scapula is not just sitting flat on the back of the body, and it kind of what it does is kind of positions that glenoid with a more anterior orientation. The scapula is also tipped in the sagittal plane, so it is 10 to 20 degrees. The superior portion is tipped anteriorly about 10 to 20 degrees. So again, it doesn't just sit flat on the back of the thorax, which would make sense because it kind of goes along the contour of the ribs. In looking at the function of the shoulder, the primary purpose of the shoulder from a biomechanical standpoint is to put the hand in a position of function. That's really what the basis of the shoulder is really for. And the combination movements we're going to break down and show what goes on at all the different joints in order to do that. Now, in looking at the orientation of the humerus, you have two angles to consider here. You have what's called the angle of inclination. The angle of inclination is a frontal plane angle, and you can see that on there. It's approximately 135 degrees. And then you have the angle of torsion, which looks at the rotational component of the humeral head relative to the condyles of the humerus. And the angle there is 30 degrees in retroversion. So you can kind of see, again, if you look at the humerus and you look at the humeral head and you put it in an anatomical position, you can see that the humeral head is kind of rotated posteriorly. Okay, so it is retroverted. So we're saying it's retroverted 30 degrees. So it kind of matches with that orientation of the glenoid being then tipped slightly and in an anterior position. And what this does is it just allows for the proper elbow joint alignment with the humerus. Looking at the motions of the shoulder girdle and what contributes to it. So when we look at the SC joint and the AC joint, because they're going to do your motions at the shoulder girdle, the sternoclavicular joint provides more motion than the SC, or the sternoclavicular joint provides more motion than the AC joint at the shoulder girdle. So the primary motion is going to come from the SC joint. The AC joint kind of just does some adjusting with the motion. Another important note, anatomically, the SC joint is the actual attachment of the shoulder girdle to the axial skeleton. So that's another thing to note. So when we look at some motions, some things to make note, when you look at elevation and depression of the shoulder girdle, there's other motions that occur with that. With elevation, you will also get some anterior and medial tilting going along with that. And with depression, you'll get some posterior and lateral tilting. Again, if you look at the shape of the thoracic region, it's round, it's not flat. So there's going to be some other tilting motions that occur with that as well. Protraction and retraction, so abduction and adduction of the shoulder girdle, where you're moving away from midline and toward midline. And you have your upward and downward rotation. With upward rotation, you're going to notice that the glenoid will face superiorly and the inferior angle will slide laterally and anteriorly. With downward rotation of the shoulder girdle, you will have the glenoid facing inferiorly, and the inferior angle will slide medially and posteriorly. Again, this all has to do with the shape of the thorax influencing that. Both upward and downward rotation occur through an anterior-posterior axis. So as the axis, and as we're going to be talking about how some of these motions take place, both of those occur through an anterior-posterior axis. Then you also have scapular tilting. So I was kind of already making mention of scapular tilting, kind of going along with the other motions we have just discussed. But pure tilting of the scapula, you have anterior, posterior, and you have medial lateral tilting. Anterior and posterior tilting occurs through a medial lateral axis, okay, so that the frontal axis, if you will, as we had talked about. One of the easiest ways to see anterior posterior tilt is if you put your hand on your low back and you lift it away. So basically, put your shoulder into your glenohumeral joint into extension. That's anterior tilt taking place with that. And then as you return back to your resting position or put your hand back against your lower back, that will be your posterior tilt. Okay? So that's the axis that it occurs through and how that happens. Then you have your medial and lateral tilting, also known as internal and external rotation of the scapula. That occurs through a vertical axis. Okay? So the medial and lateral tilt occurs through a vertical axis. With the medial tilt, the glenoid becomes more anterior. So with a medial tilt, the glenoid will become more anterior. With a lateral tilt, the glenoid start to go more posterior. Okay, so again, note those different axes that those two motions occur from. So looking here at the SC joint, so the SC joint, sternoclavicular joint, has 3 degrees freedom of motion. Is elevation and depression, which occurs in a frontal plane about an anterior-posterior axis. Retraction and protraction, which occurs in a transverse plane about a vertical axis. And rotation, okay, it goes through posterior rotation, which occurs about a medial lateral axis. Okay, and you can see that on here, that the picture kind of illustrates, based on the arrows, the axis, and obviously the axis just then corresponds with the plane. And interesting to note that the rotational component, the posterior rotation component, is a passive movement that basically takes place because of the tension on the ligaments. So you have posterior rotation because of what happens with the ligaments in the AC joint, and basically the anterior rotation is just a return to its resting position. So an important thing to note there is we always talk about rotation always occurring about a vertical axis. This is a situation where that doesn't happen. So remember that the posterior rotation occurs around a medial lateral axis through a sagittal plane. So just make sure that you make note of that so you don't confuse yourself, because we always talk about all the other rotational motions occurring at the different joints being in the vertical axis. Another thing to note, the SC joint is a saddle joint. So if you remember, we talked about what a saddle joint is. So a saddle joint has both convex and concave surfaces on each side of the joint. So here is just a slide with illustrations kind of showing you that saddle joint orientation. So you can see here where the convex and concave surfaces on each side of the joint and kind of how that joint comes together and fit. If you note, the illustration shows what goes on with the arthrokinematics. So with the roll and slide going in the opposite direction. So when you have depression of the clavicle, you notice you're getting a superior slide and an inferior roll. So obviously with elevation, just the opposite would happen. Okay, so with the SC joint, again, you have to look at what parts of the joint, given it's a saddle joint, again, convex and concave surfaces on both sides, you have to see what surface is moving. With protraction and retraction, you primarily just have the concave surfaces moving. So that will dictate your roll and slide rules with that. And again, we also did note that there is rotation that takes place. Again, the rotational movement that occurs at the SC joint occurs because of passive motion, and that's basically because of the tension that occurs in the AC joint ligaments. So here we look at the acromioclavicular joint. It's a plain synovial joint with 3 degrees freedom of motion. You have elevation and depression, abduction and adduction, and upward and downward rotation. There's a lot of ligamentous support around this joint. So if you look at the illustrations on the screen, you have the acromioclavicular ligament, and then you also have the coracoclavicular ligament, which consists of the trapezoid and the conoid ligaments. So when somebody has a significant sprain to the AC joint, the degree of separation is basically based upon how many of those actual ligaments are torn. So plenty of ligamentous support. Movement will occur around a vertical axis as the medial border of the scapula moves away from the ribs, and then as the superior border tilts downward and the inferior angle tilts away, that's movement about the medial lateral axis. So again, when you're looking at the planes of motion and what goes on with that, again, you just always match the axis with the plane. So the medial lateral axis corresponds with the sagittal plane. The vertical axis occurs with the transverse plane. So in noting the motions that occur at the shoulder girdle through the SC joint and the AC joint, it's not as clear per se as you would see with the others. So make sure that you could distinguish those. And the picture you're seeing on the screen, when you're getting some upward rotation at the scapula, this is where you're getting that posterior rotation that we were talking about at the clavicle, at the SC joint. So again, these two joints are going to work together. So there you see what goes on. So as the upward rotation occurs, the tension from the acromioclavicular ligaments are going to pull on that, causing that posterior rotation. Then as the scapula goes back to its normal resting position, the clavicle is going to do the same at the SC joint. Again, the important thing to note with the AC joint is that, again, the AC joint is the fine tuner of motion occurring at the shoulder girdle, whereas the SC joint is the prime mover, if you will. So looking at the scapulothoracic joint, okay, and some people call it a joint, some people say it's an articulation. We'll just refer to it right now as the scapulothoracic joint, where the scapula kind of connects with the thoracic region. Scapulothoracic joints are very important for the glenohumeral joint and the motion that occurs there. And, you know, we all know that, again, any type of scapular dysfunction can contribute to pathology at the glenohumeral joint. And here we have the main functions of why we need the scapulothoracic joint and why it's important for that to occur. So it helps to increase the range of motion. So again, if the scapula didn't move, you would have very limited motion at the glenohumeral joint. Okay, so if you elevate your arm through a complete range of motion, you need that movement to occur at the scapulothoracic joint. It helps to maintain optimal length tension relationship. So if you remember what we had talked about as far as muscle length and being able to maintain optimal length tension relationships to help get the most strength out of muscles that we can, it allows the deltoid to function above 90 degrees of elevation. So again, here's a situation where if we didn't have movement taking place at the scapulothoracic joint to create that movement at the shoulder girdle, your deltoid would shorten to the point where you would get some active insufficiency taking place. So by that movement occurring at the scapulothoracic joint, it allows for the deltoid to maintain optimal length tension relationships so you don't lose as much strength. The glenohumeral stability from it is just going to come from the maintenance of the alignment at the glenohumeral joint. So we know that the glenohumeral joint is a very mobile joint, but it does sacrifice some stability for that. There's a lot of soft tissue that contributes to the stability at the glenohumeral joint. The scapulothoracic joint and the movement that occurs there allows for the glenohumeral joint to kind of maintain its position well. The scapulothoracic joint also works for injury prevention. It does have a shock absorption component, so it can absorb some shock from individuals from falls. And then elevation of the body is something, this would be something that you would see, for instance, someone walking on crutches or someone doing a seated press up for individuals who have paraplegia. So it does allow for you to elevate your body. So if you think of just a seated press up, that's a motion occurring at the scapulothoracic joint to allow you to lift yourself up off of a seat, and again also too in walking on crutches, being able to push up on the handles of the crutches.